All right, hello everybody. So let's get right to it. It's chapter 14, drugs for anxiety and insomnia. You know, Wishing the best of luck for everybody in this semester because we're back at it. I'm back on my bull. So we'll go briefly over this. I'm not going to go too crazy into this because I did my best to put all the notes I wrote from when I was reading. eh, Back in winter, right? So these are all the notes that just like brief explanations of all these different things. You guys have the slides. I hate to be lazy, but we're kind of short on time, so I'm just going to kind of expedite it a little bit. Only little disclaimer: when the professor was going over phobias, if I heard correctly, she mentioned something about it needing to be over 6 months, but I'm almost positive it's referring to generalized anxiety disorder. You need to have anxiety for over 6 months to have that type of diagnosis. So again, just not sure if she was referring to GAD and accidentally said it during phobias, but that's just something I still wrote it on phobias, but I do recall the 6 month diagnostic threshold for generalized anxiety disorder. But situational anxiety is generally good, right? Because it's just the anxiety we have to get us motivated to finish something. So it's not bad all the time. Generalized anxiety, right? Now it's interfering with activities of daily living, usually diagnosed over 6 months. Panic disorder, right? It's just you have a panic attack, like, right? So it's more like a consequence or a complication of like generalized anxiety disorders kind of things. Phobias, right? Having the fear of like or an irrational fear of something. Social anxiety disorder, usually talked about as agoraphobia, right? You have a lot of fear of being judged, ridiculed, or embarrassed by others, so you kind of become a recluse. Obsessive compulsive disorder, right? I did break down that intrusive thoughts are the obsessions, compulsions are the repetitive behaviors, and PTSD, extreme situational anxiety that can occur from re-experiencing a previous like bad event, right? So I'll just get on to the next slide. Again, these are kind of real brief. These are more FYIs. Please follow the arrows because they kind of help out, kind of like track everything. But the limbic system has a lot to do with the body modulating both emotional responses, and then we're going to see in a little bit like everything to do with attention or sleeping, right? Attention is like we're awake, obviously, and then sleeping is, well, sleeping, right? So these are just examples of emotional states, right? Anxiety or fear, aggression, remorse, depression, sexual drive, or euphoria. So there's a lot of things that go on when it comes to the limbic system. And then these signals are passed on to the hypothalamus. Hypothalamus has everything to do with a sympathetic system, nervous system symptoms, right? And it's everything we've talked about before in our neurotransmitters videos related to higher blood pressure, high heart rate, high respirations, dilated pupils, etc. All those things, all those types of things that occur, it's related to that, right? And these types of things happen when a person is in like a really bad, anxious kind of situation. So that's what it's referring to, especially because the hypothalamus modulates a lot of different hormones for the pituitary. And then the pituitary releases, and it's a big domino effect. So let's not overcomplicate it. Let's just kind of note that it has a lot to do with that. This is the start, this is the end point. Right. As you guys saw, that limbic system pointed to the reticular formation, and the reticular formation belongs to the reticular activating system. So again, to be very brief and kind of just go over it because we're not going to go too much into the physio, it has a lot, the reticular formation has a lot to do with heightened awareness and arousal. And then obviously inhibition of this type of duty causes drowsiness and sleep, right? And then that reticular activating system, right? So this is kind of like the motherboard. These are the wires that push out the message outwards, right? But obviously, this is what's in charge, right? It's response this RAS, this reticular activating system, is responsible for sleeping and wakefulness, right? As mentioned, look at that. Signals of the hypothalamus to the higher brain centers everywhere and then globally throughout the whole body. And then it's typically thought to be the process responsible for all these things like anxiety, fear. And I did add this arrow because it's very big. Disruptions or issues in these types of neuronal pathways could lead to anxiety and fear. So my interpretation of this information is kind of like, imagine you are sleeping, right? You're in bed, you're completely calm, everything's good, you're just lying there. But for some reason, oh, this apparatus in our central nervous system is still sending messages as if we were in a situation that causes anxiety, right? Like a driving test or an exam that we're going to come up on. So this is what it's thought of, where there's like messages being sent incorrectly, even though we're not supposed to be having that. So that's where that's coming in, right? Um, Big giant takeaway. This is just more FYI stuff. Kind of helps us understand a little bit more, but typically my interpretation from my own notes, the RAS, this reticular activating system, helps a lot with getting signals from the spine to the thalamus, because those signals are kind of coming, like it's like what we feel, or like different things going on, right? And then that sends it to the thalamus, and then it sends it all over, and then that's where again the hypothalamus and blah blah blah, and it causes that effect. If these signals are blocked, no motion occurs, right? Again, so this has a lot to do with emotional regulation, anxiety control, and so on and so forth. Or it can cause anxiety depending on what messages are being triggered. So again, just a lot to go with it, a lot of physio. This is just to be brief. So now we're gonna kind of touch on this stuff, right? So I did start this when she was going over this in class. Stress that these symptoms could be related to something else going on, right? It could be a hormonal issue, it could be an actual disease. There's so many different things that can cause symptoms of anxiety. So that's something that, like, it has to be addressed first. It's like we've even seen in psych. It's always diagnose or like rule out all physical illness before we can really say it's anxiety, right? And obviously, CAMs are the first choice because not everyone can get an anxiolytic just off the bat. Some examples of those CAMs are the cognitive behavioral therapy, counseling, biofeedback, meditation, right? I did add this little tiny box just to kind of help out for insomnia CAMs, but also meds. So I did split CAMs and meds in two little boxes. The CAMs would be the herbs. Those include things like valerian, kava, chamomile, but meds that could help out with insomnia are over-the-counter PM labeled antihistamines, like for instance those Benadryls out there and things like that, or melatonin. Melatonin is normally if I recall right, it's it's a neurotransmitter that typically either it's a neurotransmitter or a hormone, but I'm pretty sure it's more of a neurotransmitter. I don't think it's a hormone, but it helps out with modulating sleep. When we're in a dark room, melatonin is released more, and it kind of makes us feel sleepy. More FYI. So if you guys are able to, please follow along in terms of highlights. I did my best to highlight and make those little connections and stuff so you guys can kind of reference and cross-reference through all these slides. So what I'm going to use for a CNS depressant is this light blue highlight, and then there are several medications that can help be this CNS depressant. Those include antidepressants, benzodiazepines, non-benzodiazepine anxiolytics, and then by proxy also non-barbiturates, and then we have barbiturates, right? So sorry if I kind of mixed you up there. It's non-benzodiazepine, non-barbiturate anxiolytics. So they work the similar like benzodiazepines and barbiturates, but they just not all the way. They're not one-to-one to these medications. So these are our four categories: antidepressants, benzodiazepines, this non-benzodiazepine, non-barbiturate, anxiolytic, and then barbiturates, right? So again, the biggest thing to watch out with CNS depressants is that, and she said this out loud, so it may possibly be a question, is be aware that these medications can be very addictive, especially benzodiazepines. But typically a lot of other medications are in this realm. I did use a separate type of highlight, this dark blue, to note it as a sedative. A sedative will soothe, it will sedate, relax the body. Soothe, sedate, relax the body. A hypnotic, I guess we could look at it as, we're hypnotized, we're in a dreamlike state. It can induce sleep, right? And then there are some combination drugs that are sedative hypnotics. There's obviously some independents. There's some that do both. Obviously, you can't really go to sleep sometimes if you're too anxious. So sometimes, like it's like chicken or the egg kind of thing. But there are some combination drugs, right? So these are just some quick things about education, right? She did say this out loud. I'm almost positive it might come up as a question. Big patient education point, and I just use this as like a little catch. Steer clear from driving, right? If you're using CNS depressants, it's gonna basically prevent you from, being at your tip-top shape. And if you get behind the wheel of a car and you're really drowsy or you're really sedated, you can obviously cause an accident or whatever heavy machinery. And then I did highlight, like, when she talked about, like, kind of get into it, what's causing the anxiety, because again, you want to rule out any physical illness compared to actual, like, it's just anxiety because there's no stimuli that should be causing it. But we're just going to move on. Obviously, we obtain a drug history. We avoid concurrent use with other CNS depression, other CNS depressants like alcohol. That's like the biggest one. This is why I highlighted in red, because it's really important. And I mean, generally, all these medications we don't take with alcohol, but this one is even more emphasized because of alcohol's ability to cause CNS depression. Obviously, hypersensitivity kind of goes without saying, allergic reactions, drug abuse and dependence, right? Because again, we talked about it, these drugs can be very, very, very addictive. I mean, for goodness sakes, I think barbiturates are class 2 drugs, and according to the DEA, and benzodiazepines are class 4 drugs. But again, it just varies. So they're very addictive. And then obviously, hepatic or renal issues will lead to lower doses because they have that extended time in the body, and I'm going to repeat it on the next slide too. So obviously they're used with caution with adults. They often take many medications, or they don't use as directed, typically taking more than they should. Those who are suicidal, right, with SSRIs, we have to be very careful because it can, first couple weeks of use can lead to a higher state of, causing the ability for someone to kill themselves, or, those with, again, impaired liver or renal function, because lower doses are needed. And then this just explains that, again, it just leads to extended time in the body, which will go to toxicity. I know it sounds so clear and it's obvious, but I'd rather write it down and have it there so there, not a lot of confusion occurs. And then I do remember she said this out loud. She said, remember to minimize any issues. First, we educate, right? Educate on the proper use of the medication. Will the patient use it? Who knows? But if that doesn't work, obviously a specialist has to be referred to. Insomnia, right? So kind of gonna go over it a little bit, not too crazy, right? But a lot of it just has to do with, typically, you know, sleep patterns are altered, they're prevented from working, right? Short-term insomnia can occur, right, depending on the stress. Food and beverage can also cause insomnia, right? What if you drink a whole coffee before you try to go to sleep? Maybe a little difficult depending on who you are, right? The biggest things, is that, older patients typically have issues with medication related, like sleep problems or insomnia, so that's something to watch out for. But the big thing to be very careful that could possibly come up as like a question is this rebound insomnia. So rebound insomnia occurs usually when a sedative or a hypnotic, right? Sedative as an anxiolytic, right? It soothes us. Or a hypnotic that helps us sleep is abruptly discontinued, meaning deficiency, or used chronically, which could point to it could point to tolerance, right? And then I did kind of point it out down here with this arrow. You might have to zoom in on your slides. that, it's just, again, non-pharmacologic, or CAM should be tried first, because again, these can come with a lot of risks, because long-term use of insomnia meds can lead to worsening insomnia or physiological dependence. I know, repeated info. But withdrawal symptoms, I wanted to show these symptoms of withdrawal, which is that rebound insomnia. There could be things like fever, psychosis, and seizures. Those are the life-threatening ones that maybe we should watch out for. Obviously, rebound insomnia could have an origin of anxiety, so there could be an increase of heart rate. Um, Blood pressure could drop. I'm not fully, I need to kind of review myself why that was written down, but it was stated in the book that blood pressure can drop. I'm not fully sure where that comes in, but it could be related to the shock. Sometimes, like, severe withdrawals can lead to these kinds of symptoms. Anorexia can occur. Again, I'm trying to make that connection with the anxiety, right? If we're too anxious, we're kind of panicked, we're not. Either some people can stress eat or not, right? So anorexia mainly means that you're not eating. Memory, concentration, orientation impairment, um, abnormal sounds at the ears, right? Those are hallucinations, auditory ones. Insomnia, agitation, anxiety, panic. So, right, rebound insomnia is just breaking it down. Basically, you just get back insomnia, but it's related to the anxiousness, or it could be just with the withdrawals that can occur from taking hypnotic medications for long term. So again, going brief, there's this EEG type of information, right? Please follow along with these Scooby-Doo colors that I use, right? This like Scooby-Doo green and Scooby-Doo purple. I did highlight, with regular yellow, that there's two types of sleep, non-REM, and then there's REM sleep. So I guess right now, off bat, to kind of help us remember, we'll say REM is like the realm of sleep, right? We're in the realm of dreaming. And then non-REM just means our body is resting. So non-REM is typically related to everything where our body is just down and resting. REM sleep has a lot to do with us dreaming. And we'll go into that in a couple slides, right? But REM sleep, right? There's a sleep brainwave pattern. It's kind of cool if you ever look up a picture of it. It's like all the waves that come from the body when a person's sleeping and they're dreaming. Um, but typically in REM sleep, a person could be drowsy but awake. It's kind of weird. It's like because you're kind of there but not really. It's pretty interesting. But those who are deprived of stage 3 REM, which I'm not fully sure if REM itself has a lot of stages, but I do know that non-REM has stages. I'm not sure who was referring to it, but because REM is there, people who are deprived of that type of sleep experience happen to have depression, apathy, and fatigue, right? I mean, have you ever gone some time without sleeping? You could get irritable, right? And then imagine a person that can't sleep at all. They can probably get depressed. It's a scary thing, like terminal insomnia. Those are pretty scary things. Non-REM has 3 stages, right? And then REM follows non-REM sleep. That's why, again, I don't think REM has stages, but I guess we'll just choose to ignore that perhaps on the past slide. But non-REM has those 3 stages. We're really going to care about stage 3. That's the big one that we want to care about. And then non-REM is basically right after stage 3, right? And then as mentioned before, because we're following the colors, this means REM sleep. That's where the dreaming occurs, right? So again, we're just going to go past stage 1 and stage 2. We don't really need to pay the most attention to that. Still review it if you can. But stage 3 is the deepest stage of sleep. It's when our body is actually fully asleep, when we're not even conscious about sleeping. It's that kind of fast travel effect, I guess, if you want to look at it. But by the time we hit REM sleep, remember, we're in the realm of dreaming, right? This is where eye movement happens. Like as our eyes are closed, our eyes kind of move like quickly below our eyelid, which is interesting. Um, and then, there's bursts of activities, and then dreaming occurs a lot. The mind is very active in REM sleep. It's pretty cool. It's a lot of FYI stuff, right? So now we're actually getting into our antidepressant medications, right? One of the many different CNS depression medications, right? They obviously mainly treat major depression like MDD, but they could also help out with anxiety too. There are four different categories, and I'm going to name them by safety. The most safe, that my understanding of the most safe is SSRIs, selective serotonin reuptake inhibitors. Those are the most safe. Second most safe, from my understanding, is atypical antidepressants, which can be a category of different drugs, but typically SNRIs fall under the category of atypical antidepressants. So, second safe, SNRIs. Third safe would be tricyclic antidepressants. And then fourth safe would be monoamine oxidase inhibitors. These are very dangerous and they are usually the last line of defense. They're the last option. They have a lot of just conditions that can occur with MAOIs. So now we'll move on to the antidepressants. So it's our first one, our first med. Oh, look at that! Yay! So we have escitalopram, right? Lexapro. Like all SSRIs, they increase the levels of serotonin in postsynaptic receptor sites, right? So I guess like to kind of picture, let's split this slide into three, right? We'll say over here is our axon. Here's the synapse, basically the axon, and then the dendrite. So this is the space between. All it's saying is that serotonin is not reuptake at the axon, and it's allowing more serotonin to float in the synapse so it gets to the dendrite receptor. That's what it's talking about. And then it's mainly used for generalized anxiety and depression, obviously because it's an antidepressant, but we're mainly focusing on generalized anxiety. Right? A quick tip, if you see side effects with a highlight and a gray box, that means it's mentioned later in the it's going to be mentioned later in the slides. So maybe you don't have to pay attention to that because it's already here. So just throwing that out there so you're not looking back and forth. Common adverse effects that occur with SSRIs, which luckily, again, being the most safest, they kind of have the least side effects. It's dizziness, nausea, insomnia, because serotonin, if you have seen our neurotransmitters videos, still has a lot to do with messages being sent, movement, motivation, kind of all those types of things going on. So even then, because you're increasing these neurotransmitters, they could still send more messages in the body. Obviously, they're going to help those depression-like symptoms, but they also have a lot to do with, cognition, like, attention, cognition, all this type of stuff, being awake, being attentive of everything, energy. So that's where the insomnia comes in, right? The dizziness can occur, I guess, because of, again, like it's too much stuff. I mean, usually more often than not, something that we've caught on when we study is like whenever we use CNS depressants, dizziness kind of happens a lot. So that's kind of a big like blanket kind of statement to use for a lot of these antidepressants. Somnolence basically kind of piggybacks off of the insomnia, right? Like you're not just you're restless. You can't get to sleep. You're sometimes like just really really out of it, and you're way too restless. Confusion, right? You're gonna get confused whether you have too much insomnia and you don't sleep, or you're just confused because again, a lot of these messages are going on, and sometimes you're feeling really out of it. You're kind of overstimulated in a way. So confusion again can occur also because of just like the whole aspect of sometimes just antidepressants working their magic and being a CNS depressant in a way, right? And then seizures can occur because again, there are certain things that can happen when there's too much serotonin in the body, and again, there's too many messages. We talked about how seizures can be just like primitively way too many messages, way too much stimuli occurring in the body, and then we have a seizure because we short out. So that's mostly associated with overdoses of SSRIs. I know I said with confusion, it's kind of weird because I said depressant, even though, see, it's not really fully doing a depressant but effect, but it's still it's in that realm of like messing with the nervous system. So obviously, if you mess with the central nervous system, you're going to cause some kind of confusion. That's kind of what I wanted to clear up. As for this, right, antidepressant, it's an anxiolytic, it's an SSRI. I mainly highlighted the things that are most important. It's kind of like trying to filter out the fluff. I already said that it increases serotonin in the synapse, right? So it just results in that antidepressant activity without any of the production of symptoms of sympathomimetic or anticholinergic activity. So again, if you saw that video of the neurotransmitters, you just by looking at sympathomimetic and anticholinergic activity should know the set of symptoms that can occur: dry mouth, blurry vision, urinary retention, constipation, high heart rate, no sweating, hyperthermia, a lot of different things just by looking at this. So again, it does help a lot to know that neurotransmitter slides that I shared, if you guys are able to. And then another thing that it could help out with is panic disorders, which is kind of, connected to the whole anxiousness that can occur. So obviously, I wouldn't picture it being a rescue drug because SSRIs work over time. But kind of interesting just to know, like, hey, look at that. It's that domino effect that I was talking about. Like, knowing your neurotransmitters will help you kind of capture that. But this is another reason why SSRIs are so safe, because they don't have a lot of side effects like SNRIs, TCAs, and definitely not like MAOIs. And they don't produce these types of side effects like those drugs do. One of the biggest complaints with those drugs is the anticholinergic or sympathomimetic effects. And luckily with SSRIs, those are kind of more minimized, right? Big thing again, it takes time for it to work. Plasma concentrations need to go up and it takes about a week. But give or take, we'll just say, because SSRI, right, we'll just use that as it takes 4 weeks to get an SSRI to work, right? There goes those adverse effects, right? There's a gray box, right? Dizziness, nausea, insomnia, somnolence, confusion, seizures, if taken with overdose, right? So again, as mentioned, it was repeated. Um, Big thing, she did state this, and this does come up in the book a lot, even in our psych book. Doses will always start low and they will slowly go up. Doses should not be given at high because, again, now transitioning to the black box warning, antidepressants like escitalopram or a lot of other different SSRIs can increase the risk of suicidal thinking and behavior in children, adolescents, and young adults with MDD, right? Major depression, right? And it's not approved for children under 12 years of age. So, what this is trying to say, and it was really nice to hear that in psych, is that it's not necessarily that these SSRIs make you like mentally want to hurt yourself. It's just more that you've always had that feeling, but major depression also leads to a lot of fatigue and a lot of like weakness behind it where you can't really do it. SSRIs don't treat the cognitive parts of depression or the behavioral kind of psychosocial issues. They treat the physical symptoms, which a lot of it has to do again with the fatigue and the weakness and kind of that mental block that you get. So when you take these SSRIs, they now, if you had the plan to do it and then you take, the only thing holding you back was the energy, and then now all of a sudden you get this energy, that's where the risk comes in on a person taking their own life. And then obviously just being mindful about that. Hey, it can't be given to those under 12 years of age. Um, Obviously, if it can't be given, if breastfeeding, typically it's a blanket statement. These types of drugs are not used when it comes to people who are pregnant or breastfeeding. So kind of a blanket reminder, blanket statement, and they cannot be used within 2 weeks of MAOI therapy. The reason why, we'll get later into why MAOIs are so dangerous, but you'll figure it out why when we cover it there, why they should not be used within that time frame. Okay. All right. Now, so here we are with drug-drug interactions. And look, there it is actually. There's the reason why. So MAOIs naturally break down neurotransmitters. And it's not talking about only serotonin. It's talking about a variety of neurotransmitters. Dopamine. I believe they also break down acetylcholine. They break down norepinephrine. They break down a lot of neurotransmitters. Obviously, serotonin is one of them. So MAOIs do a lot of jobs, right? But MAO, sorry, that's monoamine oxidase. That is the enzyme that breaks things down. But if you inhibit this enzyme, it allows for these neurotransmitters to just be out and about and like not really be hindered, and they're working. So imagine if now you have this crazy concentration of dopamine, norepinephrine, acetylcholine, and serotonin all just like packed up in your central nervous system. That can help lead to serotonin syndrome. I highlighted it with orange to kind of capture the pattern, right? So serotonin syndrome, there's a lot of autonomic hyperactivity because too many messages are occurring. Hyperthermia, again, too many messages can lead to that. Same thing could be about the rigidity, right? Because we talked about it, it has a lot to do with contractions, sweating because of the hyperthermia. And then there's neuroleptic malignant syndrome, which we talked about also in the neurotransmitter video. It's that rigidity, the high fever, the organ damage showing increased levels of creatinine and altered consciousness kind of stuff, right? And they could also lead to a hypertensive crisis because, again, too many messages are being sent with these MAOIs, right? It still leads to like body regulation of perfusion, and that could cause the whole blood pressure spiking. And then obviously autonomic instability because there's too many messages being sent. I guess interesting, unique thing, they can increase the levels of metoprolol and cimetidine. Metoprolol is our beta blocker. Cimetidine is one of our, I think it's one of our original antihistamines that are not used as much because they got replaced by more like safer drugs. Obviously, use with alcohol is going to cause more CNS depression, so careful with that. Like always, it's a blanket statement for. All right. Now for herbals, right? Again, watch out with St. John's wort. Be careful with that because it could cause serotonin syndrome. So I highlighted under orange to kind of remember from the last previous slide. And obviously they just increase the effects of Lexapro, which is this escitalopram. Treatment of overdose, there's no specific treatment. It's just treat the symptoms, and those are the symptoms that we went over in the gray box before.
St. John's wort is like a natural.
It is a natural antidepressant.
And it has serotonin, so
Mm-hmm.
that's why.
And it again, that's why it also increases the effect. Yeah, so same good catch with that. St. John's wort is a natural antidepressant with serotonin-like properties. That's why it increases the effect. SNRIs, right, are atypical antidepressants. So it didn't really go that crazy into the whole thing about like these drugs. It didn't give like all the little categories and stuff because typically a lot of these drugs work the same way, especially SNRIs to SSRIs, but with like a couple little differences. SNRIs, they have anticholinergic like effects, and they have less compared to TCAs, those tricyclic antidepressants. But either ways, these anticholinergic effects can still show up: the constipation, the dry mouth, the abnormal vision, blurry vision basically, and the tachycardia and things like that. They can cause weight gain, same thing with SSRIs, and sexual dysfunction, same thing with SSRIs. As a blanket statement for everything, there's going to be the weight gain and the sexual dysfunction. I guess the only one that where weight gain might not happen all too much is sometimes with SNRIs, but because it's here on our slides, let's go with weight gain. Sometimes, again, it's like everyone's a little different and these drugs are a little weird and everybody kind of responds differently. So, but let's go with what's on our slides. But there it is again, sympathomimetic effects. There's less of them and less anticholinergics. So again, you see these, you'll recognize them immediately once you get those neurotransmitters down and like what happens if you block them, right? And then here's some other side effects, right? Abnormal dreams, sweating, tremors, right? Which is weird. We talked about anticholinergic doesn't mean that you'll make secretions or sweat. One of the most unique side effects about TCAs, so this applies to TCAs too, and atypical antidepressants like SNRIs, is that you sweat with them. That's just something that unfortunately you just have to memorize because even though they do have anticholinergic effects, which shouldn't allow for sweating, it happens. So it's very unique to those two drugs. That's why I put very odd side effects. But the abnormal dreams, like we've mentioned in the neurotransmitter videos, people take Benadryl, right? And they can like take it as a recreational drug and they take way too much. and it could lead to hallucinations, weird dreams, and kind of stuff like that. So that's where that's coming in. But again, unique side effect, sweating with TCAs and SNRIs. And then now that transitions over to TCAs. So TCAs, again, these actually have full-on direct anticholinergic effects because they target muscarinic receptors and block them. But so that's why I highlighted in this dark blue the ones that are related specifically to anticholinergic effects, the dry mouth, blurred vision, and urinary retention, right? Biggest takeaway that makes these even more unique, right? Like we want the unique stuff, right? Because these are all kind of acting the same. These are not for patients who have a past medical history of an MI, a heart block, or an arrhythmia. The reason why this happens, and TCAs work very similar to SNRIs, right? SNRIs, they prevent the reuptake of serotonin, norepinephrine, and wow, that's it. Just those two. TCAs do the same thing. Now, the reason why there has to be a consideration for those who have heart issues or cardiovascular issues is because TCAs, for whatever reason, happen to get caught up and stay in cardiac tissue. They build up in cardiac tissue. Now, we talked about, again in our neurotransmitter video, norepinephrine modulates beta 1 and it helps make the heart work harder because beta 1 has everything to do if we agonize the effects, if we increase, because this is what's going to happen because norepinephrine is prevented from being reuptake, so it touches the receptors more. It's going to lead to the heart pumping harder and faster. And what if they, at a risk of an MI, they're going to get an MI, or they've had an MI before and they haven't taken care of their health? What about a heart block, right? Their heart is already unable to pump like it should. And now you have this norepinephrine targeting those receptors and telling it, hey, work harder, but the heart can't do it. And then obviously arrhythmia is a type of, heart block is a type of arrhythmia, but that kind of goes into like the many different others. So again, biggest takeaway with TCAs is that they are not for those with the MI risk, MI history, or heart block arrhythmias because of that collection in cardiac tissue. And I almost feel like this might be a question because this is a big safety thing. All right. And then finally, our last antidepressant, MAOI, is the most dangerous one. And we went over why they're so dangerous because, again, monoamine, to review, monoamine naturally breaks down serotonin, dopamine, norepinephrine, and I feel like I'm blanking out on one, but and acetylcholine, right? They break those down. But if you inhibit that enzyme that breaks things down, it's going to lead to so many different things that can be bad. Professor did also say in class that it could increase the effect of anti-diabetic or insulin drugs. So you might want to keep a note on that. But the biggest takeaway with these MAOIs is to avoid tyramine foods. That includes the fermented fruits, vegetables, salty processed meats like salami, your sausages, kind of things like that. Cheeses, whether fermented or any like cheeses in general, aged or whatever. It's anything that's fermented, really, like anything with like heavy bacteria, like kind of catch up or like salty kind of process. That's what it is. Beer is fermented, right? Alcohol in general, like whether it's still, just stay away from it. And pickled foods, because again, that's fermented. So the biggest reason why is because if you take MAOIs and then eat tyramine foods, they can lead to a hypertensive crisis. And again, that's because of all these things going on, and then it's like these more messages are being sent that's leading to this hypertension to occur because you're already breaking down, you're stopping the thing that normally breaks down neurotransmitters, and that's what leads to that hypertensive crisis. Now we're going to go on to our benzodiazepines, right? And as a little fun fact, it's said in class, it's often the first line drug for anxiety and acute care, right? Big thing is that it binds to GABA receptors and intensifies the effect of GABA effects. Now, what does GABA do? If you watched our neurotransmitter video, We talked about GABA, and GABA is all in charge of inhibition of the central nervous system. It tailored towards anxiety and insomnia because GABA is everything to do with inhibition. So we want to increase those levels. It's good to bring it up because that calms the body down. In comparison to some other drugs where it's a lot of blocking, we don't want to block. We want to increase those levels to help that anxiety and the insomnia. So this is a side effect you'll see later, but drowsiness, dizziness, respiratory depression, especially with IV routes and high doses. But therapeutic doses don't typically give respiratory depression unless, again, overdose or in IV. But big thing to watch out, right? We talked about it. GABA is a CNS depressant. Obviously, you're going to get drowsy. You're going to get dizzy because we talked about it's a blanket statement for everything. And then the respiratory depression kind of just goes hand in hand with the CNS depression. Benzos and old people, right? She talked about this, and they may have a paradoxical effect. And as mentioned before, that means to every of these drugs. They're all intended to relax, but sometimes they have that counteracting effect, and it causes more restlessness. And to minimize those issues, because maybe who knows, this might come up in a case study. We might get like a benzo that's an IV form and a PO form, and our patient's old. PO forms are used over IV because they have a slower release. Because benzos in old people typically don't mix, especially if they're maybe um, negligent to this medication in the way that their body has never taken it before. They're very new to it, and that might hit them like a truck, and then it overworks them, right? So obviously, we have different types of reasons why they can be used, right? I did put this in a gold box. It's an anesthetic adjunct. In addition to being, something for anxiety, something for sleeping, or insomnia, I should say, right? So the big thing is that an anesthetic adjunct, why would that be? So, for instance, my father recently had a minor surgery that happened in his nose. He had to get some things removed so he can breathe better. He was given a benzodiazepine, such as lorazepam, because he had to be intubated because they had to put him under in order to do the surgery. So, people are going to get stressed, especially in the hospital setting. They're already stressed as it is, right? And the big thing with it is that in order to calm people down before, intubation or any type of surgery, sometimes these benzodiazepines, from my understanding, are used to help calm a person down before they, do the big anesthesia thing, or they do the whole intubation stuff. So that's kind of an interesting little yellow box, and maybe that might come up as a question. Who knows? Okay, and then here's that gold yellow box again, the whole anesthesia, but lorazepam, right? And big thing with, luckily, all these benzodiazepines, they end with pam at the end, or lam. So a lot of pam or lam kind of stuff. But for in the instance of lorazepam, right, it's one of the most potent benzodiazepines, and it has an extended half-life of 10 to 20 hours. So I guess we'll just picture a strong woman, Laura, and she's very strong and has, the whole extended life stuff to kind of help us remember, oh, it works a lot, it works over time. Same thing, like a lot of benzodiazepines, they are used for seizures, especially status epilepticus, which basically means a seizure that won't stop and it just keeps going. And then they could also be helped for chemotherapy-induced nausea and vomiting, right? uh, big red safety. Whenever anything is in red, it means it's either safety or like a very important thing, right? For instance, the extended half-life might mean that less frequent doses, right? Like maybe once a day dosing. But for the instance of IV routes, you have to monitor respirations every 5 to 15 minutes, and the airway and resuscitative equipment should be accessible because their condition can change, and then they could go under, and you have to intervene from there. And it's a category D drug, so if you ever see this little tornado, I like to use that as a way to remember this is not safe. for pregnancy. Okay. At the bottom again, adverse effects, drowsiness and sedation. That effect of drowsiness and sedation, a person could get used to it over time. What the heck happened? Oh,
Go.
we're good with this slide, right?
Yeah.
Yeah.
You kind of stopped halfway through. Do you want to finish it or do you want to just?
Oh no, we can finish. Yeah, we can finish.
Yeah, I paused it right now. So.
Okay, we're good, right? We're
I'm
rolling.
recording right now.
Okay, cool. And we were on this slide like we just started, right?
Correct.
Okay, cool. So the side effects of drowsiness and sedation, they can decrease over time. So as a mental way to remember that, we'll remember our elderly patients that end up taking more than they should. Because maybe, if you ask them, why are you taking more? It's very likely that it's because, oh, they're not working as they used to. So I have to use more, right? Because now you need to have a higher dose or like more frequent doses in order for that to work, right? Because the effect decreases over time. That's why these benzodiazepines are not usually used for chronic issues. They're meant more for acute, like kind of short-term issues, right? And then obviously higher doses or the IV route will cause that significant CNS depression, like the amnesia, the weakness, the disorientation, the ataxia, inability to move, right? Or like difficulty moving, sleep disturbance, blood pressure changes, blurred vision, double vision, nausea and vomiting. So these are your heavy bad side effects that maybe are good. These are your late term or like, overdose or like heavy potency symptoms compared to the simple drowsiness and sedation that occurs. So, big focus on the red. Contraindications, right? They're not meant to be used with patients of acute, aka closed angle glaucoma, right? Or there it is, closed angle glaucoma. So acute narrow angle, which I mean narrow and closed, very similar, right? Because that could lead to permanent blindness. Could be that maybe a certain type of receptor in the eyes are kind of holding it together, and you using these benzodiazepines basically like it was holding it up, and then now you just gave that CNS depression, and then now the eye, it closes up, and then now you become fully blind. Misuse or excessive use of drugs, obviously, liver disease, impaired brain function, or thoughts of suicide. And the main thing is because again, if you're already in a heavy depressed state and you have these thoughts of suicide, these are going to depress you more because they're CNS depressants. So that's where you have to be being careful for, right? Impaired brain function, right? Because it's going to be one of those chicken or the egg. It's like, are they impaired? Are they altered consciousness because of the drug, or are they altered consciousness because of a disease process, like a stroke or brain trauma, or like increased cranial pressure or something like that? Drug interactions, right? There's going to be multiple drugs that they get touched on, right? Use with other CNS suppressants, including alcohol, surprise, surprise, increases the sedative effects and increases the risk of respiratory depression, right? And death, because it's going to lead to it if it's not addressed. The symptoms are those visual changes, which we've talked about before, nausea, vomiting, dizziness, and confusion. Again, these are heavy, CNS depressant drugs. You're going to get confused with them. Funny enough, they actually counter the effects of anti-Parkinson's disease drugs like levodopa. Levodopa, again, going back to the neurotransmitter video, levodopa happens to be increasing dopamine levels for those with Parkinson's disease because they can't move that well. So dopamine helps with like motor control, right? Now, again, we're increasing concentrations of dopamine, which have a lot to do with, stimulation and function and control up here. And then imagine you're taking a benzodiazepine that is also, we're increasing the concentration of GABA. And GABA is that neurotransmitter that does everything in terms of inhibition of the CNS. But we were taking levodopa to stimulate the CNS in order for it to work. So they kind of have that counteracting thing. They conflict with each other. And it could be possible that a benzodiazepine could, there might be more of an affinity to that drug than levodopa. So that's where, explaining why is it that, benzodiazepines counteract these types of drugs, right? And they could increase levels of phenytonin, which is a anti-seizure drug. Um, that's something that just has to be, I guess, we'll just remember that, I guess, in a way, because it inhibits our body, right? We're not digesting much, we're not metabolizing much. So phenytonin stays in the body for longer. So finally, we get to our herbals, right? Use cautiously with herbal supplements. We mentioned them before: kava, valerian. There's chamomile again, or hops. Never heard of that one before, because they have an additive effect of CNS depression. That's why these are in that light blue, CNS depression. Red is the contrast of that light blue, right? Stimulants like Gotu Cola, which I'm just going to call it Goku because Super Saiyan. And then there's Mahuang, which we'll just say, like, hey, because these are stimulants, right? I mean, when we go into a test for Professor Huang, we're all stimulated, we're all anxious, we're all that, so who knows, maybe that might come up on an exam. And, obviously these just counteract the effect of an inhibitor. So that's why it reduces the effectiveness of the drug. But finally, and this is going to be a blanket statement for all drugs that have to do with GABA, the overdose treatment of lorazepam or anything that ends with those, PAM, like, there's so much PAM, LAM, kind of different stuff, right? Um, is flumazenil, right? It's a benzodiazepine receptor antagonist, which we talked about what benzodiazepines do. They agonize GABA receptors. So this drug, flumazenil, is a GABA receptor antagonist. And that is going to be for all of these drugs that we're going to touch on that do GABA, that work with GABA. So it's a blanket statement for benzodiazepines. It's a blanket statement for barbiturates, and it's a blanket statement for non-benzodiazepine, non-barbiturate anxiolytics, right? Or GABA agonists, right? So flumazenil is very important to know because that is our OD treatment for those GABA drugs. Now we're moving on to barbiturates. We're almost done. You guys are almost done hearing me. Trust me, I wouldn't want to hear me too that much. But this diazepam here, again, it ends with PAM. A lot of barbiturates typically have a very similar naming structure, and they end with barbit. Like there's phenobarbital, there's barbital, like pentobarbital. So I believe this diazepam, this Valium, was placed here by accident, so I crossed it out because this is a benzodiazepine. And I don't necessarily think that it falls under the category of a barbiturate. So I feel like this was possibly a typo. So let's not pay attention to this diazepam. This is a benzodiazepine. Barbiturates always will end with barbital, like phenobarbital, pentobarbital. Like that's the nice thing about barbiturates. The big thing is that, and you'll look at it better on the slides than you will see in this video, is that it works like a benzodiazepine, but with an exponentially stronger effect that is capable of depressing the central nervous system function at all levels, everything: cardiovascular, respiratory. Those are honestly the most important because that's what keeps the body running, right? Same thing, it binds with GABA and it intensifies the effect of GABA, and it inhibits brain impulses, right? CNS depression, because they're legit. Barbiturates are legit benzodiazepines, but imagine like a benzodiazepine multiplied by like a million. They're very, very strong. And unfortunately, these types of drugs are used for people to take their own lives. In fact, that was mentioned in the book. Nowadays, they're rarely given. They're rarely like prescribed for those with anxiety and insomnia due to their significant adverse effects. They're really, really risky to take. Um, Low doses will cause drowsiness. Moderate doses will cause inhibition of seizure activity. So there's another indication there for seizures. And it can help with sleep. There's that insomnia, right? The hypnotic. and the sedative of the drowsiness for, anxiousness. High doses can cause anesthesia, and obviously really high doses or unmonitored high doses can lead to death because a person's whole body can shut down, right? I added these from my notes in my book. They are a Schedule 2 drug, right? So they're highly addictive. Withdrawals can be fatal, and they could cause that profound respiratory depression, hypotension, and shock, right? Because our whole body, it causes cardiovascular collapse. Big thing I do want to take away from this, right? Adverse effects, right? Tolerance. Let's talk about tolerance, right? Very similar, like how it was talked about with benzodiazepines and how the effect of that drowsiness and that, like kind of confusion or whatever that was talked about, or sedation that can come from a benzodiazepine, you build that tolerance after a while. The same applies to barbiturates. The body gains a tolerance to like the CNS, kind of like, that whole like relaxing, that sedative hypnotic effect. However, the body never builds a tolerance to the effect of respiratory depression. So same thing, a person might overdose on barbiturates because they take way too many because they don't work like they used to. So now I got to take more. But now because you take more, those doses become at toxic levels, and now that causes a like complete respiratory depressive episode and you stop breathing. So again, tolerance is very big in barbiturates. You gain a tolerance to the desired effects, but not to those adverse effects like the respiratory depression.
I just want to see a question out of that.
I could 100% see a question like that because that's a major safety thing. That's very true. And obviously, we talked about it because it's a Schedule 2 drug. The closer you get to Schedule 1, the higher dependent or like higher addictive it is, right? So there's that physical and psychological dependence. And I'm so sorry because yesterday when we uploaded the slides, I forgot to highlight these two just to point out that these are barbiturates, right? There's that pentobarbital, secobarbital, butabarbital, phenobarbital. Those they will always end with barbital. So again, I feel like that one up there, where it was talking about diazepam, that Valium, that is a typo. I'm almost confident that was a typo by mistake. And then there's that respiratory depression that constantly comes up, and a lot of other different things, but these are the big ones that come from barbiturates. So those are the big safety concerns. And then finally, we're almost done. We're at the final lap. We're going to be talking about non-benzodiazepine, non-barbiturate CNS depressants like zolpidem, right? Ambien, right? Same thing. It binds to GABA receptors, but it's primarily used for short-term 7 to 10 day treatment of insomnia, of acute insomnia, basically, right? Adverse effects, same kind of stuff, but it's going to get interesting right now because we're going to go into it. Mild nausea, which you can kind of say about any drug. Dizziness, right? Because it's a CNS depressant, and it's also the whole thing with GABA, right? A natural inhibitory hormone, or like function, right? Diarrhea, which again, kind of like a statement for all medications. Daytime drowsiness, right? That one's a little different. Amnesia, oh my gosh, that one. Sleepwalking and eating while asleep. And then I guess as an additional other drug that is non-barbiturate CNS suppressant or non-benzodiazepine is Buspar. So maybe watch out for that one, right? But now we'll go into this drug a little bit more, right? We're doing a callback. We're doing a callback, right? Here's that Scooby-Doo green, Scooby-Doo purple. This drug, zolpidem, this Ambien, preserves stage 3 of sleep. We talked about what stage 3 is. Stage 3 is our deepest point of sleep. And then it has only minor effects of that REM sleep, that realm of dreaming. So the big thing is because your body physically needs rest, right? And we need to preserve this stage 3. That's why now I'm starting to think that it was all from those slides, it was more people who don't get stage 3 non-REM sleep are the ones that are irritable, can get depression and that agitation or whatever that comes with it. I'm not really thinking that it has much to do with the REM sleep, but again, case in point, it preserves stage 3. That's the most important part. It gives us to actually rest. Again, only indication, right? Because all these other drugs, they're a hypnotic, they're a sedative. However, this one, the only indication is a hypnotic. It is for short-term insomnia management. There are other forms, to give sublingual tablets like Edluar, and oral spray, Zolpimus, right? Zolpidem, Zolpimus, kind of a, it's on the cheek kind of thing, right? Fun fact, I guess, the FDA had to adjust dosing specifically to women because for whatever reason, when it comes to women, they happen to develop higher concentrations faster than men. Who knows if that comes up in a case study question. This has to be given very, like right before sleep. It has a rapid onset, 7 to 27 minutes. Give right before sleep. Category B, that means it's good, right? No little tornado. She did say out loud in class, right? She did say this. Adverse effects occur more when this drug is given and sleep doesn't occur after. So the main takeaway that I'm getting at when it comes to these other adverse effects like sedation, mainly confusion, amnesia, and like the other stuff where like weird dreams and such, it's like dreaming but you're awake, right? And she talked about it. It's like you give those drugs, and she said that like sometimes the patients can get really loopy and start having hallucinations. It gets really weird, and it's very tough, especially when they're in hospital settings where you're in and out. They hear the monitor, they're not really asleep, but they still take this medication, and again, it preserves that stage 3, and it helps, like in point with non with REM sleep. So you're in that realm of sleeping, but you're also kind of awake. And now you're like it's like you're passing dimensions in a way. And like now you're physically here, but your mind's kind of somewhere else. And then now you're seeing things. So I think that's where it was coming in. And then obviously, there goes the depression with suicidal thoughts because that was talked about earlier. It's still depressive. So it can make you still kind of, get to that point and make things worse. But this was the main takeaway. This is what happens. So, like, just imagine your body wants to physically sleep, but you can't, but you're still dreaming at the same time. It's a little trippy. So, that was something interesting to take away from that. Um, so, even though this is a category B, so it's okay, I guess, during pregnancy, lactating women probably shouldn't take, right? So there's that big tornado, right? So it has like it has a little bit of a term. Like it's not, it may be okay to take in pregnancy, but when you're lactating, probably not, right? Because it gets to the baby. But here goes those adverse neuropsychiatric reactions that we were talking about, right? When you take it and you don't go to sleep directly, it causes hallucinations, sensory distortion, basically hallucinations, whether they're visual or auditory, sleepwalking, which, whoa, and then nocturnal eating, which was mentioned beforehand, right? So pretty trippy side effects, huh? That's what happens with Zolpidem, right? And one of the nice things is that Jonathan came up with like Z's, right? Like 3 Z's.
Do it at the end.
Yeah, we'll do that at the end. We'll put a little picture out, or like put it on our grids. But it was like a nice thing related to sleeping. Yeah, so it was kind of cool. It's just like Zolpidem, right? Like 3 Z's, a lot of sleeping, right? And then like the big side effects are all these neuropsychiatric stuff. And then there's that repeat about women who have significantly higher concentrations than men. So that's why doses might have to, right? Obviously, they'll increase more sedation with CNS depressants like alcohol. Wow, we've said that like so many times, right? Shocking, right? Phenothiazines, right? They augment CNS depression, right? So just careful with that one. Just not entirely sure what phenothiazines are, but I'm gonna just take away that they sound like phenobarbital, right? Phenobarbital, that's dangerous. And if they augment CNS depression, that means they're just gonna make it worse, right? So I'm just going to use that as a like slant way of remembering. When taken with food, absorption is slowed, which typically happens as general statement for everything. So it's just, I guess, a big thing. Like, right, if you're going to give it to a patient who's going to go to sleep, obviously they shouldn't probably have a like nighttime snack too, because then it won't come out and then they won't go to sleep. Like, the onset might be delayed. So that's probably what it's going on about. And then finally, right, overdose treatment. Immediate gastric lavage, right? So they're pumping your stomach, if I recall, that's what it is. Or like they're suctioning everything out, right? Or like, washing it out where appropriate. And then look at that, flumazenil. And then we have the brand name, Ramazicon, right? It got repeated just like the benzodiazepine slide. Benzodiazepine, aka GABA receptor antagonist, so it helps block it. It's the same effect as like opioids, right? They're opioid receptor agonists. Narcan is an opioid receptor antagonist. Same effect. And then finally, I think we can kind of call this one was done because that's it. So best of luck. Thank you guys for watching, and hopefully this helped out kind of maximize your understanding. See ya.